Okay, thanks everybody for joining us. I'm going to go ahead and get started. I'm going to eventually here let Linda introduce herself, and but I just wanted to do a quick introduction of the topic today because I think it's really one of the most important issues that's kind of facing the behavioral health field in general. And uh, and it was probably one of the main reasons that I had gotten involved in advocacy around this issue is, I always thought when somebody was sick, you could just pick up the phone and you call the doctor and you make an appointment and you get in and you get a diagnosis and you get treatment. But in this particular area around behavioral health, we find that that's not always the case. And so um, I asked Linda to be able to come and talk a little bit about it. Linda's been an advocate for a long time around this issue. And it's important to kind of put it into a somewhat of a historical context because the reason that we've gotten here um, has to do really with the, kind of structural changes that we made from a policy standpoint. So thinking back to really the early days of this country and the way things were handled around mental health in the very early days, there was not anything structured around it at all. Our country was a very, rural country at that point in time, and if people happened to be born with a behavioral health issue, a mental health issue, it may completely go undiagnosed, and that may be okay because that person could function well enough to be able to get along in the society that they were in at that time. And as we kind of grew as a country and we became more urbanized and people were moving into the cities, some of that type of behavior was no longer able to be tolerated. And so people try to look for ways to work with some of those folks that let's say couldn't get along in society. And there was a variety of different ways that that was handled. Some people may be, shunned from the home and they were out on their own. Others end up in poorhouses, or in some cases would end up in jails or other places where people were, let's say, put where they could be taken care of. And as we continued to grow, there was a lady in the mid 1800s by the name of Dorothea Dix who who kind of went around and started to realize that this was really a terrible situation that a lot of these people were in. They were languishing in jails or other facilities, or you couldn't even call it facility, but there were places that these people were not getting any kind of care. In fact, were being abused or neglected. And she came up with this idea that there should be a, a place where these folks could be taken, where they could get therapeutic care, and they could, be able to live a life as well as they could to the best of their capability. And that effort started what became the state hospital system around the country. And so nearly every state in the country had several state hospitals, these grand buildings that we see where people were able to be taken and with the idea that they would be able to get to be able to get care. And that um, seemed to work. But over time, those facilities became overcrowded. Over time, in some cases, there was neglect taking place there as well, even abuse. And so, what happened was, as a society, there were articles that were written, there were exposés that were put out there, and news programs and everything to kind of show what was happening in some of these facilities, and it was really, really dreadful. And so, as a country, we decided that this is not what we want to be doing, and so we made a conscious effort to begin to move away from that asylum system. And in California, that resulted really in legislation that was known as LPS Act or the Lenterman-Petrus Short Act, which began to downsize, almost eliminate, but downsize the asylum system in the state of California. And what that did is it kind of put people into two different tracks. I mean, it created a track for what at that time was called maybe mental retardation. Today we would call it developmental disability. So those people that were designated as having a developmental disability would have one track of the system that was pretty well set up. I mean, I'm not saying that it's perfect, but there was resources and a system set up for the developmental disability track. And then there was a track that was set up for those folks that were suffering from mental illness and alcoholism. And that track was assigned to be taken care of in the community or going to be community-based healthcare centers that were going to be set up to be able to take care of those folks. That community-based system never really got off the ground and was never really established or funded. And what it meant in practice was that families kind of had to deal with this situation on their own. So if they were unlucky enough to have somebody born in their family who had a mental illness, it was really incumbent then upon the families to be able to handle that. And in order to do that, it meant families were going to have to navigate a lot of really siloed systems or even non-existent systems in some cases to be able to try to get treatment and care for their loved one. And I'll, that's sort of where we are today. There's been some, of course, many different developments in the last 60 years, but we're still in that situation where the full community care system has not really been fully developed. And with that, Linda, I'll kind of let you introduce yourself, and then maybe if you can, just talk a little bit at the beginning about what is it like to try to get treatment for somebody who is a youth. So if a youth is presenting as having some type of mental health issue, what's the process now to get care for that person? And then maybe also talk about that if it's not a youth, but it's also if it's an adult.
Well, hi. Thank you for having me here to talk today. I really appreciate it. And as you can see by this slide here, falling through the cracks, the challenges of treating serious mental and what I call brain illnesses, because we know that that's what they are today. I will say that to get a youth into treatment is not nearly as hard as to get somebody over the age of 18. And why is that? Well, when you're younger, your folks can have they have control over you, so they can help get you care. If you're 18, parents lose all the rights to make you do anything. And if your child becomes psychotic and they are away from you in college, you really don't have you may not even know they're sick because colleges don't inform parents of that anymore due to privacy laws. So the typical age of onset is 15 through 25. So that means a lot of people don't get sick until they're over the age of 18. The other challenge there is that if the person is in psychosis and they don't think they're sick, and that condition is called anosognosia, and it's a neurological condition that basically turns off any self-awareness the person would have that they are sick. So if they come in and they have those conditions, then the only way you can find out what's going on is if they sign a release of information, an ROI. And if they're super sick and they don't know they're sick, and if they're paranoid of their parents or other people, which is also a symptom of that, then they're not going to sign it. So you're kind of locked out if you're a parent. You're locked out because of that and because of stringent HIPAA laws or HIPAA laws that are not being interpreted correctly by doctors and clinicians. So I hope that answers your question. It is terribly hard for parents of adult children to get them treatment. And that goes for adults in general. If you have a family member, a loved one, that's why then we have to go to the rules and laws of the Lanterman-Petrus Short Act, which is almost 60 years old and is antiquated and is actually a big barrier to getting people the urgent medically necessary care they need. Um, so with that, I'm going to go into, well, slide 2, and I'm going to ask you a question. So, oh, somebody's talking.
Sorry.
Um, so we've all seen the human tragedies on our streets, people struggling in crisis, sick. Whoop. Hey, John, thank you. um, Struggling, sick, hungry, and this fella here seeking human kindness. I mean, it's very sad. So how do you feel when you are walking by people suffering on the street? Do you just look away, feeling like you can't do anything to help? Are you fearful and rush by? Do you wonder how these folks got to such a low point? Why can't they just lift themselves up and ask for help? Do you think they are lazy and choosing this lifestyle, or are they just beyond any kind of help? Let's explore these assumptions and answer the question, why is it so hard to intervene with these folks and help them? By most people and doctors' standards, we would consider these folks to be gravely disabled. What does that look like in real life? I'm going to share a story with you. Um, oh, well, actually, first I'm going to go to slide 3. Sorry. People laying on the ground with untreated sores, unable to provide for their own food or shelter, emaciated individuals begging for food and help, or people in active psychosis responding to commanding voices that we can't hear, but they can hear, and are walking into traffic and really risking their lives every day. So, one of our county families shared this story of their homeless son who was obviously in psychosis and in crisis. He believed his food was being poisoned, and therefore he would not accept food from people that were walking by or from anybody else. He existed by eating garbage out of the garbage cans. He has schizophrenia, a severe brain disease that is treatable, by the way, and he was in psychosis, which is a detachment from reality, and that's a symptom, paranoid and hallucinating. His mom called several county officials to try to get him into the hospital for medical care, but was told that as long as he could pull himself up on the rim of that trash can and eat food from the garbage, he was not considered gravely disabled. This is the kind of medical barrier to care, to a barrier to medical care that our families are facing, trying to get their adult loved ones into restorative treatment. So, as Bob was talking about, it is really down to the California Lanterman-Petrus Short Act that was enacted almost 60 years ago. And this law was governs access to involuntary treatment and conservatorships. And it was written in a time when the main goal was releasing people from the old asylums that Bob was describing. The result, the bar for getting into mandatory treatment was raised so high that today we can't get people the urgent medical care they need. The reason? The policymakers did not want the creation of any new asylums. So the community treatment centers were supposed to be funded, but largely they were not, helping create the situation that we face today. Slide 4. Very ill people are cycling through homelessness, emergency rooms, jail cells, and too often death. In 1967, when the Lanterman-Petrus Short Act was enacted, there was little understanding of schizophrenia, bipolar disorder, and other brain diseases that exhibit with psychosis. There were few medications and little hope for any kind of a recovery. Estimates suggest that 30 to 40% of our national 771,000 people that are unsheltered are severely mentally ill with brain diseases and or substance use disorders. Approximately 392,000 are in jail. Can you imagine if we put people with stroke, Alzheimer's disease, or cardiac diseases in jail cells for treatment? People would be up in arms and outraged. We have criminalized brain illnesses instead of offering humane treatment early enough to prevent entry into the legal system to begin with. So, our outdated legislation has not kept pace with medical and scientific progress. We now know that these no fault brain diseases are treatable chronic conditions and that many people can reach recovery and do reach recovery. But we are still treating these illnesses like legal matters and limiting involuntary care for our sickest. And we are talking about a subset here. We're not talking about extending involuntary care to everyone. That's not the intent. It's for the subset of the most ill who don't know they're ill. So, slide 5, please. So, our state must oh, must legally abide by the LPS Act of Grave Disability. As this slide shows, recently, for the first time in almost 60 years, the LPS Act was amended through California Senate Bill 43 to include substance use disorder, personal safety concerns, and necessary medical care. Now, this is a major, major step in the right direction. If, and a big if, it is implemented consistently and systemically. Another key issue is even if it is adhered to, is we have a bed shortage. And not only a bed shortage, we have staff shortages along the entire continuum of care, which encompasses crisis care, in-hospital care, inpatient medical care, residential care, and intensive outpatient community care with supportive housing. That is a major factor in who actually gets life-saving treatment in our county and in our state. The Social Security amendments of 1965 established the Medicaid program. So now we're talking about at the federal level. It was designed to ensure that states would have the primary responsibility for funding long-term psychiatric care. It included the Medicaid Institutions for Mental Diseases exclusion, or the IMD exclusion. This prohibits federal Medicaid funding for care provided to patients 21 through 64 in psychiatric or substance use disorders facilities to 15 beds or 16 beds or less. Think about that. Only 16 beds or less. You can't build a hospital with any kind of services with that few beds. And its purpose was to encourage deinstitutionalization and prevent federal funding from supplanting state funding on psychiatric hospitals. But the result was reducing state treatment beds for mental diseases. Can you imagine if we limited treatment beds for other organ-based diseases? This is blatant discrimination with terrible results. And it also demonstrates that the pendulum has swung too far from one extreme to another, from all the old asylums and, actually Dorothea Dix, she started her work because people were being siphoned to homelessness, jail cells, and other terrible environments. and put them in the asylums. Well, now what we have done is taken them out of the asylums and put them back in to jails and homelessness. Does that really make sense? It sure doesn't to me. The other way to get folks treatment involuntarily is based on a dangerousness standard. If a person presents a danger to themselves or others, the result is that this population, which faces a very high suicide risk, as well as victimization by others, is being labeled as dangerous just to get them into necessary medical care. So I want you to think about this for a minute. Can you imagine being told by county officials and law enforcement to kick your very sick son or daughter out of the house to wait and see if they get picked up by law enforcement to get medical care in jails? It happens all the time in our county. And would we do this to our parents with Alzheimer's or dementia? Of course we wouldn't. So we're talking about people who can't even meet their most basic needs, but they don't usually qualify for involuntary help due to our laws. So we've discussed the LPS high threshold for getting the involuntary and why the law was written that way. There are also built-in protections to honor people's civil rights. An attorney is required to represent people in hearings that they're held in hospitals when somebody is brought in by law enforcement on a 5150, which we'll talk about a little bit. They have 72 hours, up to 72 hours to decide whether or not that person needs to stay in the hospital for further treatment. And they have to come up to a hearing officer, and those hearing officers are through the judicial system. The doctors, usually two doctors, write down, let's say, why they want the person to remain for more extended care. And unfortunately, those hearing officers who are not medical professionals, they can release the person, and they often do, before any extensive treatment is provided. And we're seeing that today on our streets. So, slide 6, please. So, why this high threshold and why the law was written that way was really what it is doing is it's not getting suffering people what they need, the treatment they need to recover and thrive. Why? We have not incorporated the clinical reality of these treatable no-fault diseases that should and into systems that should respond to them like any other medical emergency. Our county officials involved in the process, clinicians, law enforcement, first responders, attorneys, judges, are not well trained in the nature and symptoms of these illnesses. They are not healthcare professionals. So, why are people refusing help? Because that's another problem. Are they in denial about their illness? Slide 7, please. When the brain is malfunctioning, as in psychosis, people may experience delusional thinking, hallucinations, and paranoia. That's why they often cannot process and respond to officers' or others' commands, which can lead to the tragic outcomes we have seen in our country and in our county. Reality-based decision-making capacity is gone. People often cannot access treatment without involuntary care because our systems in San Diego and across the state still rely heavily on voluntary participation in programs and services. So most people don't know that the number one barrier and reason that these sick folks can't request help on their own is because of this neurological condition of anosognosia, which is a brain-based lack of insight, which renders people unable to recognize they are sick. It affects the frontal part of the brain. So it appears not only with schizophrenia, 57 to 98% of the time, and bipolar disorder, 50% of the time, But with other neurological medical conditions like Alzheimer's, Parkinson's, and stroke, which are treated immediately, it is not denial, but it's often treated like denial by our slide A's. So, in other serious medical conditions, medical teams immediately begin life-saving treatment. With schizophrenia, bipolar disorder, and depression with psychotic features, legal processes often become part of the decision. This delays care and prolongs brain-damaging psychosis, worsening long-term outcomes. The longer that this psychosis goes untreated, the worse the prognosis. Is this just or humane? Denying life-saving healthcare to very sick folks who can't help themselves is just plain wrong. Can you imagine your dad suffering a stroke in the street and the physician can't begin treatment until a legal opinion is rendered? Our mental health officials and others responsible in our country and state need much more education and training on these treatable brain diseases so they can better understand what the sickest individuals are experiencing. To understand the person and their behaviors, one must understand the illness and its symptoms. With that knowledge, appropriate treatments can be offered with compassion and understanding. So even when we try to help, there are system failures that get in the way. Our system is definitely crisis driven and reactive rather than proactive. Instead of getting these ill people the timely medical care they need and deserve, we wait until a stage 4 medical crisis to meet the high mandatory treatment standards. By then, they are extremely ill and have already cycled through ERs, homelessness, arrest, and jail cells. Advocates call this the never-ending churn. Their chances for a robust recovery diminish the longer they are in brain-damaging, untreated psychosis. I know I've said that before, but I'll say it again and again, because this is something that I don't think people in our county recognize. So not only is this a violation of their human right to health care and to be well, but it is also unethical, inhumane, and costs us more money. Right now, what I call the cost of not caring or the neglect tax in our country for severe mental illness is, according to the Journal of American Medical Association in 2026, $343 billion. Families, particularly the moms, often serve as the major unsupported caregivers in our society. Many give up their jobs to keep their loved alive because our siloed system, which doesn't communicate with one another, is not doing their job. And again, a major bottleneck is limited treatment capacity. We don't have enough beds at all levels along the continuum of care, including the supportive housing step downs or enough workers. The Treatment Advocacy Center, which is a wonderful resource, and I have it on a slide down here that you might want to look on their site, recommends an optimal number of 60 beds per 100,000 people. California has a dismal almost 15 beds, or approximately 5,700 beds, with a shortage of nearly 14,000 beds. Many of these beds are occupied by incompetent to stand trial forensic patients coming from jails. We have had a 90% of our psychiatric hospital beds lost in this country. The biggest treatment facility in our state is not a psychiatric hospital, but the Twin Towers Jail in LA. Think about that, the Twin Towers Jail. So what happens when people do receive medication and high quality care, then are discharged too soon back to the street? They will relapse. Why? Because they need structure and continuing care to keep them improving. The street and jails are definitely not healing environments. So these folks are like all of us. We all need people, place, and purpose in our lives. That's why supportive housing with services is essential in the continuum of care, or what advocates are calling housing that heals. People with severe mental illness need much more than medication to recover. A pill doesn't do it, and it takes time to heal brains. We are not following a gold standard medical practices in our state. Effective support means building care teams that help people retain their stability in the community. So, what are the ethical implications of involuntary treatment? When someone is in psychosis with anosognosia and no decision-making capacity, is it more humane or ethical to leave them to deteriorate on the street or jail cells, or is it more humane to compel treatment? And who should decide? Disability rights groups in California continue to fight against any type of involuntary treatment. These folks exert tremendous influence on our legislators who don't understand the clinical realities of these diseases. Can a person fully exercise civil liberties after losing reality-based decision-making capacity because of brain illness? Can they really exhibit their freedoms? So, what exactly is actually working? People in psychosis with anosognosia do not and cannot volunteer for help. And that's why most of our voluntary programs, like the Community Assistance Recovery and Empowerment Act, the Care Court, and Assistant Outpatient Treatment, AOT, are not working. If you do not enter into an agreement with Care Court, there's no pathway for conservatorship with longer treatment. Your case is just dropped and you're released. But there is hope for improvement with this program. Slide 9, please. So you can look at this slide and we can just talk about it. There is new legislation, California Senate Bill 1016, and it is legislation that will authorize petitioners, including families, to submit evidence for mental health evaluations to the court directly, aiming to facilitate court-ordered, thorough professional evaluations by a medical professional for individuals. Right now, we don't have this kind of evaluation being used, and I'm going to talk about that a little more. And two, we can extend practical use of existing LPS tools, such as 5,200 evaluations, which must be done by professionals and can be requested by families and others, as opposed to the current and less thorough 5150 assessments, which are part of the legal law systems. Unfortunately, actually all of California's 58 counties, including our county, do not use this existing tool to help get more people into treatment. And that is the goal, to get these people into life-saving treatment. And three, promoting alignment of a system-wide alignment of California Prop 1, which is a $6.4 billion bond package aimed at reforming the state's mental health system, in part through infrastructure buildouts. This will focus on housing and on intensive services for our sickest. Over 4,300 housing units and 6,800 mental health treatment beds will be funded statewide. Four, also, plans are being developed in each county with public input for the best ways to spend Behavioral Health Services Act, BHSA, dollars. That's a millionaire's tax, sorry, millionaire's tax, and that will more focus on those with the most severe illnesses and substance use disorder and co-occurring disorder. It aims to close service gaps, enhance oversight, increase data collection, transparency, and accountability at the state and local levels. And finally, five, this is a very hopeful thing that I will really be anxious to see how this works out. Plans are being made to make Metropolitan State Psychiatric Hospital near LA into a healing community of a continuum of care model. And likewise, our San Diego Psychiatric Hospital grounds, which received a grant money from the state, they are also working on a continuum of care facility. The key is to have experts design and implement these facilities to best serve this population. All of us need to hold the county accountable for executing these state mandates. Now, I'm going to start closing the talk and then we're going to open it up for your questions. So Bob kind of asked me, what do I wish more people understood about this issue? Well, again, and I've said it very many times, these are treatable conditions, neurological, medical brain diseases, and they deserve prompt treatment just like any other organ-based diseases. The terms mental and behavioral are misleading and imply people are making choices about their behaviors. Do we talk about cancer this way? People do not choose to have cancer, schizophrenia, or substance use disorders. If I could change three things tomorrow, I would lower the barriers to involuntary treatment and conservatorship when needed, not forever, but for a small group of people, and until the people regain their ability to make informed decisions about their own care. At that point, they won't need this kind of treatment. And add more acute psychiatric beds and continuum of care facilities at every level. And supportive housing is so important. We do not have enough in our county and across our state. And increase the number of practitioners dedicated to serious mental and brain disorders. So slide 10. So how can you help? I know this slide is packed, but I'll just go over a few things. And then I also have a couple slides with resources that you can go to. So how can you help support this issue? Well, you can help by supporting legislation like the one that we've talked about, California SB 1016. How can you go about doing that? Write to your state representatives. Go to nationalshatteringsilencecoalition.org for educating pamphlets on legislative advocacy, psychosis, crisis care, and more. Educate people around you about what you learned today and inform your elected representatives at every level, local, state, and federal. Demand county support for implementation and execution of recently enacted California SB 43, which redefines grave disability and offers a path to get people into treatment quicker. Hold our behavioral health department with its $1.2 billion budget accountable for directing funds into effective programs with transparency. Demand outcome data. A significant portion of these funds are intended to support severe mental illness and substance use disorder. Support more treatment beds and supportive housing all along the continuum of care. This includes writing letters of support for federal House Bill HR 2022, which would delete the IMD exclusion, which is quite an arbitrary rule, by removing it from the 1965 Social Security Act. Remember, this is just a pull out of the hat 16-bed limit for psychiatric facilities to receive federal funding. Support policies that encourage medical students, interns, nurses, clinicians, and social workers to enter the workforce. And most of all, show kindness and respect for our sickest citizens. Remember, they did not choose to get sick with these severe diseases. Slides 11. This is a slide that shows you some things that would be very good to read. The first one is of an advocate, Eric Smith, who got his sanity back through an AOT program in Texas. And he did threaten his mom's life. He refused to get help because why? He suffered from anosognosia. And Eric is a great example of how recovery can and does happen. He is a wonderful advocate. He does clinical, well, I won't say clinical, but he does counseling to people that have these illnesses. He is part of a team in Texas in the criminal health courts. And Eric was kind enough to agree to be in this People article, which it took me 3 years to get an article on anosognosia in a magazine that had a huge following. 81 million people read People. I guess that's a little bit funny, but anyway, that is something that I would suggest all of you read. I believe it came out, yeah, oh, there it is, February 15th, 2023. And there's a link in the next slide. And then these are the pamphlets I was talking about from the National Shattering Silence Coalition. Um, these are downloadable and printable. You can do a pamphlet form, or you can do the full page form. Really valuable information for people that don't know that much about advocacy for severe mental illness. And then lastly, this is a piece that was in recently in the Los Angeles Times and then later picked up by the, I keep wanting to say Chicago Tribune because I'm from Illinois, but from the San Diego Union Tribune. This is Dr. Aaron Meyer. He is the behavioral health officer for the city of San Diego, and he's also a clinical professor at UCSD. Aaron and Anne Marie Council started this 5200 campaign, which ended up in this legislation 1016, which they wrote. And it just got out of the first committee this week and is in appropriations right now. Next slide, please. Here's some resources. And if you don't get a picture of this, I'm sure that we can supply it for you. These are some of the organizations I was telling you about. And this is a link to the People article, which also had two online articles which appeared too, which may be linked to the article. And now, slide 13, please. I want to wrap it up, and I'd like to end with two of my favorite quotes and then open it up for questions. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Dr. Martin Luther King Jr. And the last slide is my favorite empowerment quote of all time by Margaret Mead. Never underestimate the power of a small group of committed people to change the world. In fact, it is the only thing that ever has. Thank you.
Linda, thank you very much. I really appreciate the presentation, and we can open up for questions if somebody has some questions.
Linda, this is Alan.
Hi, Alan.
You were talking about how some of these bills are influenced by the privacy advocates and blocking some of not recognizing that people can't really help themselves, so they need other people to look after them. So, how much work is going on to educate the privacy advocates about how their wrong perceptions?
Well, Alan, that is such a good question. We've been trying to educate them for years. They don't want to hear us. They say all involuntary treatment doesn't work. But you know what? I know tons of people who had involuntary treatment and it saved their lives. And they say that. They say it saved their lives. So I don't know. We're working on other ways that we can you know, maybe these folks don't want to be educated. I don't know. Their venue, and they are great at all other disabilities, keeping people's rights. This is a disability that is not typical. It is, as you probably heard from the presentation, it's in a totally different way. And it actually takes people's rights away by affecting their brain, and they can't exercise their rights. So all of these things we've talked about have legal protections. When people are put into involuntary care, it's not like you just put them in and warehouse them. It's not like the old asylums at all. And we have drugs now to help them. So that's a good question. And when you come up with the answer, please get back to me because we've been trying for years to get them to back off. They really should not be overseeing these particular brain diseases.
Thank you.
Welcome.
Do you see me? My face
Oh,
isn't on the screen. It's Julia.
Sorry to,
yes.
yep, go
Hi,
ahead.
Julia.
Hi, thank you for doing this. I have a question about the substance abuse disorder. I call it dual diagnosis.
Yes.
And I struggle with that piece of it. How it how it goes. I don't know. I get the mental health crisis and getting that diagnosis. There's an attraction toward use of drugs for many people who have these serious mental illnesses. When does it go from I just want to escape my brain and use something to, you know, ease it for a little while and then makes it worse versus it becoming an actual like disorder? Because I struggle with that.
Well, I will say this. We call them co-occurring disorders, and they're the most difficult to treat because once the person turns to the drugs, it's hard to separate out what is the mental illness, what is the drug influence. And when you see that people have lashed out in anger and hurt other people, probably I'd say times out of 10, they have a co-occurring disorder because drugs can make you violent. Not that psychosis can't, because it can too. But that is a very good question, and I think that we have neglected substance use disorder, and that's why it was a big deal when they put that in to some of this legislation. Because at the time, I recall when I was listening to our behavioral health advisory board, we just didn't barely had any treatment facilities for drug use, and drug use is definitely a kind of a brain disease because once it hooks into you, you are dependent on that drug. And so I'm not sure exactly, I'm probably not really answering your question, but I just want to give you kind of a scenario. It's messy, but the way we are right now and what we're putting into the laws, I'm hoping that we will be able to address this better in the future and get these folks help that they need. I mean, I know some people that have both, and the drug part can often be the hardest to get rid of. And if people get put on antipsychotics, uh, then of course you would assume maybe that they would taper off the drugs, but then by that time they're hooked. So that it takes two different kinds of therapies, and there are not that many talented people that can do that work. So therefore, you need treatment facilities that have both types of experts that can do one and or the other.
Um, can I also add to that? Because um, part of, today we're organizing this as part of the Rotary Action Group on Mental Health Initiatives. And uh, two of our objectives are to raise awareness and break the stigma associated with mental health. But picking up on the addiction side of things, there's actually another Rotary Action Group called Addiction Prevention. Um, and they're organized differently from us. They're organized by country. And 5 to 10 years ago, when we started talking to them and saying, hey, we should be working closer together because of addiction and mental health and behavioral issues, their reaction is, no, no, addiction is not a behavioral health issue. And so, even amongst our dear colleagues within the Rotary community, we had to do a lot of work to change that perception. And I'm pleased to say now that that perception has changed, and
Good.
we're working closer with the Addiction Prevention Rotary Action Group to try and recognize that this is a it's not everything is a simple one thing or another. So as you
No.
said, they're very complex, but at least we should be aware of that. And I'd really hope that we can actually start doing more from an addiction prevention program in the context of behavioral and mental health. So that's something that we're working on, Edu
Good.
educating us, the Rotarians, associated with this. So thank
You
you.
know, I think that that's excellent work. I mean, sometimes people have their territories and they have
Yeah,
fixed beliefs about their
yeah. Yeah,
somebody's doing.
one of the nice things, Linda, about working with Rotary is that everyone's got the same service before self is our motto. And so everyone's looking for the right way to do things. Yes, they can have passion about certain subjects, and sometimes that passion may be slightly misdirected. But at least you can have a coherent conversation about it, and that's what's happening. So I'm heading down to a
I,
conference, a Rotary conference on Saturday, where mental health is being presented as our action group is being presented to the Rotarians there.
I think that's great. I think the fact that you can talk together even when you disagree, we could use a lot more of that in a lot of other areas. But yes, I think it's so important. And for me, the stigma part of it, and I'm not living with a condition, either one of those conditions. I find that many things called stigma are really just blatant discrimination. So if people have in their minds, that somebody is choosing to do this or that, maybe they did choose in the beginning to take a drug, okay? But maybe they had their reasons. Like maybe they were hallucinating and scared out of their mind and they didn't want to go in to a doctor. Or maybe they were on the street and the only way to survive was to take amphetamines to protect themselves, especially women, and not sleep. There's so many scenarios. So it's good to hear that that the Rotary is addressing these issues. And I did hear from Bob too that you educate youth as well, that you have youth on campuses, and that's so important because they're the next generation. They're going to carry on this work, and they tend to be much more accepting. At least my kids tell me of conditions like bipolar or schizophrenia, because they grew up with kids taking pills for ADHD, for, different things, and it just became normal. Oh, Joe has ADHD, so he has to take his pills. So that sort of thing. I didn't grow up with that at all. I mean, we never talked about those things, until we got into high school where they did the no drug campaigns and all that. By that time, it's kind of late. You should be starting that right away when kids are younger, and telling them what to look out for in their friends as they get older and the kids go to college, because that's where a lot of the first breakdowns occur.
On the high school side of things, one of the things that we're looking at is how, especially peer counseling, peer-to-peer type work, whereby the high school students can recognize depression and anxiety, um, and then lead them to the right appropriate resources to be a friend, be someone that they can speak to. But they don't have to treat them. Obviously, they don't treat them, but at the same time, they can have show respect and begin to recognize. And we're beginning to see more and more high school programs whereby there is a meeting in the school gym of this subject. It's at least it's being talked about now, and we we're beginning to hear high school students coming back to us and saying, "Yeah, we're talking about this. We're having these peer counseling groups."
I love that. And I think young people, like I said, they're our future. And if they're educated early on, then I would hope that some of this stigma is going to dissolve. Because I think one thing that, when people get into recovery, whether it be from drugs, um, brain illness, or both, they don't need any more, I don't know, negative forces coming at them. So I do know that stigma can be really bad because I have heard people discount these folks, just like, oh, they're just a waste. They're a waste. And no, they're human beings and they're not a waste. They just are ill. So that's an important thing because on the streets, when people are acting out, that is what the public sees. And that is some of the negative views come from that. Treat them up front, they're not going to see that as much. You know what I'm saying? They're going to be in treatment and hopefully in some kind of recovery. So I like that you do that, starting young, starting
For
the
the
kids young.
for the Rotarians on the call today, one of the things that we've done is to enroll District 5340, our Rotary District 5340, as a oh, Bob, help me out. What's the name for it? The San Diego Behavioral Health. What's the name of the partnership? You're on mute, Bob. Yeah.
Part of the Live Well San Diego.
Thank you. Live well, San Diego.
Oh, okay. Live
Yeah,
well, San Diego.
yeah. And so the
That's
idea
that's
that
good.
the idea of that is to look at how we as Rotary clubs, Rotarians, can actually coordinate our activities back into especially the San Diego County Behavioral Health Services projects and things like that. So,
Do you know of New Path, which focuses on drugs?
uh,
New
uh,
Path
no,
organization. You might
no.
want to look into that too. My fellow advocate and colleagues, uh, Carolyn Stewart and Anita Fisher, are active in that, and they promote treatment, not stigma, not discrimination, and all of that. And it's amazing the job that they do. I just think that kind of work is so needed, and there's not enough of it. So you guys should give yourselves a pat on the back that you are doing this in our community because it really is essential if we want to get anything going that will help these folks. And that's the whole point of all of this, to help people get the care they need so that they can live, survive, and thrive. And, that's it. That's the meat of the matter. Mm,
That's right. It's about getting the right treatment for the right people.
that's right. At the right time and place.
There you go. Anita, or Linda, thank you. You said Anita, and now I'm saying Anita.
It's
Li-
okay.
Linda,
I
thank
don't
you so
mind
much.
being.
No, thank you very much. It's really been helpful, and I think we'll share out the video on our website for sure, and be able to make the slides available as well. So I want to thank you for taking the time to do this for us. And unless there's any other questions, I think we're going to be able to go ahead and close the meeting.
Yeah,
Great.
Thank you.
Linda, thank you so
Thank
much.
you.
Time
Thank
and
you for
knowledge.
having me.
yeah. Well done, Liv. Well done.
Thank
Yeah.
Appreciate
you.
it.
Have a good
Thank
afternoon,
you.
everybody.
Bye-bye.
Okay. Bye now.